the cardiac surgeon is with you.
I hope we don't have any cardiac surgeons here. Okay. Good afternoon, everyone. Thank you all for coming in on your weekends. Would like to thank the GIS for inviting me, and also would like to thank Medtronic for hosting me here. Is this working? This one here. Is it working? Can you run from here? When? Okay. It's not working at the minute. Even this, it's not working. Oh, okay. All right, now it's working. Thank you again. I have no disclosures regarding this topic. Special thank you to our colleague, Mrs. Lamisa Shahani, one of our CVTs, for helping me arrange these slides. So we'll start with the case. It's a 65-year-old gentleman with no prior coronary disease, history of hypertension, hyperlipidemia, CKD stage 2. He's an ex-smoker and uses GAT. He also has no family history of coronary artery disease. In May of 2022, he presented to an outside hospital with an NST elevation MI, and at that facility, he underwent coronary angiography. This coronary angiography was done back in May in the outside facility. As you see, there's an occlusion in the LAD diagonal, and also has severe stenosis in the left circumflex coronary artery. His cranial picture also shows occlusion in the LAD diagonal. These are also more pictures showing how extensive disease he had. His RCA also showed severe stenosis in the proximal and mid segment, with a very nasty looking proximal segment. Looks like an ulcerated plaque. He also has severe stenosis in the mid posterior descending coronary artery. The vessel also gives collaterals to the RCA, to the LAD, I'm sorry. And like you can see, as you see, it appears to be a very short CTO of the LAD. And you see it on this picture here. This is his ECG on arrival to our hospital, and that was in August of 2022. So that was 3 months after his initial presentation. His echocardiogram did not show any significant valve abnormality. Has a normal left ventricular function, 50 to 55% with no wall motion abnormality. His RV was also normal function and size. His apical fourth chamber also showed a normal left ventricular function. So at this stage, the patient went for a coronary artery bypass surgery, and that was on August 9th. He underwent a lima to the left anterior descending coronary artery. He also underwent a saphenous venous graft to the obtuse marginal and a saphenous venous graft to the posterior descending coronary artery. His intraoperative course was uneventful. He also underwent an intraoperative TEE, which was also normal. So he was immediately decannulated in the OR, was taken off the bypass pump, and was transferred to the cardiac surgery ICU in a stable condition with acceptable pressor support at that time. He continued to do well until 4 hours after that, and that was like around 10:30 at night, 11 o'clock, where he decompensated, became hypotensive, started requiring more pressor support, and this was his ECG at that time. So due to that, the cath lab was activated, and we decided to take the patient back to the operating room. However, before we went to the cath lab, The patient underwent a transthoracic echo, which showed severe hypokinesis in the anterior wall and apical wall as well, which is unusual for his ECG changes. Which, if you can look back at his ECG, he had some inferior ST elevation with an inferior posterior involvement. But his main affected area was the anterior wall and the apical wall as well. So we took him back to the cath lab, and immediately we obtained access in the right common femoral artery. His diagnostic showed stable anatomy in terms of the left native system on the caudal pictures. The LED is less visible at this stage compared to his last images. Even on the cranial picture, you cannot see the LED as you did on his initial presentation back in May. The only thing that you notice is that there's a backfilling into the vein graft of the obtuse marginal branch here. So we engaged his saphenous venous graft to the RCA, and at this stage it's occluded. And as you can see, there's actually some stenosis at the anastomosis site of the vein graft. This is his saphenous venous graft to the OM, despite an excellent flow in the graft, but there's severe stenosis just at the ostium of the graft where the anastomosis site is. So now we have another problem here. This is another picture just showing the ostium and how tight this graft looks. The RCA, the proximal mid-RCA looks almost unchanged. However, if you look distal to the mid-posterior descending coronary artery, you notice that there's loss of flow in the PDA, which can explain his symptoms and why he decompensated as well. However, this is his lima now. So he lost his collatus from the distal PDA, and also lost his lima that was just placed in the operating room. So at this stage, our surgeon was in the cath lab, and we had a lengthy discussion about what to do next, and I'd like to hear your opinion of what should we do next. So he's on levofed right now, increasing dose of levofed. Yes.
At what doses, and is there?
He's almost maxed out on the levo.
Okay.
Almost.
So I think obviously continue with the conversation that we had, and I'll come back to the angiogram. Then while the decision is made whether to do PCI or graft revision, I think the discussion should be hemodynamic support while the discussion is going on about PCI. What was the thought process at that point?
So at this stage, we went with the PCI option.
No, I mean, what was the discussion about hemodynamic support for the patient while...
So his blood, despite being on max support, his blood pressure was okay, his lactate was okay. So we did not feel the need that we need to start him on any hemodynamic support at this stage.
Okay.
And that the decision should be, should we take the patient back to the OR for graft divisions, or should we proceed with the PCI?
Sure, so PCI. We'll get to that in a second. Any of our cardiac surgical colleagues in presence and want to comment on what you see on the angiogram with regard to grafts?
Oh, hi, hello there. Yeah, I'm a cardiac surgeon. Hi, guys.
Hi, Dr. Bauer.
I would say the proximal vein grafts seem to have been quite poorly done, actually, without obviously trying to be critical. But and also the next thing is that actually reopening will be very simple. I assume it's a short number of hours after the surgery that this complication has taken place.
I'm sorry, I can't hear you. Sorry, I apologize.
It's a relatively short period of time after this complication took place. So reopening the chest would be very, very simple to do, actually.
Sure.
But my first obvious thing I'd say is that the proximal vein grafts, I think there's a technical issue with the way that those grafts have been constructed, actually. I can't fully understand what's going on with the left internal mammary artery, but I'm still processing.
Yeah, it appears there might be even a thermal injury, like even the proximal segment of that. I don't know, you're a surgeon probably, but there might be some issues in the proximal segment of that lima. It could be just some thermal injury as they're dissecting or closing the small, I don't know.
Yes. Yes, I mean, it's hard to comment, but there's obviously something quite badly wrong.
So Dr. Barber, from surgical standpoint, based on the timing, you would favor graft revision in this case?
Yeah, I think as a surgeon, we'd automatically be thinking, take the patient back and revise. To be brutally honest, and speaking very openly, I think most surgeons, assuming they've had a good track record of success, usually if there is a complication, there is usually a sort of intellectual state of complete incredulity. I don't believe this is really happening. And I think actually it's quite important that there are other minds at work with a contrarian view looking at these studies. So I would say that the involvement of my cardiology colleagues when I experience difficulties in my surgical cases is vitally important.
Thank you for presenting this nice case. I mean, this is a complex case for sure. And always with bypass, it's always, for me, it's always a mystery trying to find out where is the problem,
Absolutely.
where is the area of ischemia.
Absolutely.
And I think I like your comment about mechanical support. I mean, if a patient hemodynamic are good on high pressors, the patient is unstable. And I don't think we should be reassured that the hemodynamics are good because someone on pressors.
Sure.
The hemodynamics are good at the expense of end organ perfusion. You have a really good high central pressure because everything is vasoconstricted.
Absolutely.
So I think pressors, we should stop thinking about the knee reflex of putting pressors. Pressure is good, I'm happy. It should be a temporary intervention until a final or ultimate treatment is done. I think I'll be concerned of doing PCI on this one without mechanical support. I think, and one way of thinking about what device to use, you asked that question, is the degree of vasopressor support. So if you are on 1 high dose or 2 medium dose pressors, you probably need Impella CP or more. So in this case, I would recommend, if you're going through the PCI route, which I think partly because the patient on high pressors, the surgeon didn't want to do, because they don't think they can probably do a patient may not be stable enough, but I would start by putting Impella CP.
Well taken, well said
Well,
point. I
well
think
taken, absolutely.
by the time, and that was the point I was asking, because I think you have a patient essentially with acute myocardiogenic shock, is a post-CAMAGE acute myocardiogenic shock. Go ahead, please.
Your point is very well taken. So it was kind of a lengthy discussion where to go next with our surgeons. But my question would be now to all, I'm sorry? Here, it's occluded, I'll show it to you. If you go back here, here. Sorry, go back one more.
I think the same process that led to the occlusion of the graft led to the occlusion of the PDA.
Yes.
So probably this is a distal graft anastomosis issues that led to closure of both points.
Yes, it's all technical here at this stage. So, and my question now to the audience here, and now for the PCI, what the option would be. We have a CTO on the LAD, and then you have probably the culprit, which is the PDA. What would you do next? Would you go after the PDA first? Would you go after the LAD? You have a fresh open chest, the patient can go back to the OR. So that was also the debate where to start. Patient is sick, he's hypotensive on pressors.
Should he do PCI, or should Dr. Barber take patient back to the OR?
Yeah.
No. Because the LAD is miserable from the beginning. I don't want to put my colleague in the same situation again. I've seen a clip, almost a clip in the LAD. I don't know what's this. Maybe he has something. If you see the echo he showed, RV is severely impaired. The RV is severely impaired. So I wouldn't be happy to send him for the surgeon because of this alone. He will not get out of your bypass. Because RV is severely impaired, you can see also in the angio of the RCA, the native RCA, it has a good, nice collaterals to the LAD. So the culprit by far is the RCA or the graft of the RCA. When it's occluded, it causes ischemia. You can see now the RV, how it's contracted. It's almost not contracting.
Yes.
I would go to the native RCA first, but because of this RV, I would go for ECMO first.
Okay.
Not Impella, ECMO. And I have the power, the surgeon is with me inside the cath lab. We'll put an ECMO, then we'll go PCI to native RCA, which supposedly it should be the easiest one. Then you think after that about this will fix RCA ischemia and the LAD ischemia from collaterals. Then after that about the OM graft, you can do, it's a recent graft, so it's very difficult to stent acutely while he's just a few hours stitch. But for me, I would fix this RCA definitely and try to stabilize him on ECMO before even starting PCI.
Very good, sir. So just by show of hand, how many people would put a mechanical circulatory support in this patient before any revascularization, whether it's surgical or interventional? Okay. Well, it was, so now ECMO, the first question was mechanical circulatory support. ECMO, okay. How about Impella system, whether it's Impella or Bipella?
Okay.
Okay.
Sorry, surely if he's going back to theatre, he'll be on bypass in about 10 minutes.
You vote for surgery. Okay, so how many people for surgical revascularization? And how many people for PCI?
Is he the same surgeon or
Same surgeon.
So
Same surgeon.
You're going to share data with us about post-cabbage PCI and the so-called. So I'll not steal the time. Go ahead, please, with the case because we get to the data as well.
Of course, we went for PCI. So, so because of that difficult LAD CTO, I thought, this now it's 12:30 midnight now. This is exactly, we're all exhausted. We just woke up. So we decided to go for the LAD first. If we fail, this patient was going to go back to the OR. So that was the final.
The native LAD.
The native LAD.
Despite the ECG findings.
Yes. We'll give it a 5 minutes attempt. If we cannot open the LAD, then the patient is going to go back to the OR. And the surgical team was on standby, waiting to take the patient back to the operating room.
Question.
for
So
revision.
what was the take of the surgeon? Why he doesn't want to take him back? Does he have a strong reason?
He's going to go back and probably he's not going to get a lima. His lima is probably gone. And that's
SPG.
before the surgery. I can go back all the way back before
So
the
I
surgery.
think that's actually a great question. One of the challenges I think we face and I face, anytime the LAD is occluded and the LAD feels bicollaterals, you think you can see the LAD, but you may not see the LAD well, and whether how good of a target vessel the LAD is or not. And I think this was the case here. I wasn't sure whether there is some disease in the mid to distal LAD or not, and it's likely that there was, and the graft was put exactly.
So here are the
at that location.
collaterals. Here you can see the LAD on the collaterals. This is pre-cabbage. So you can see there's a very short CTO just after that calcium, if you can see it. Yeah. So I'll show you the native LAD here. You might see some good pictures of the native LAD.
So let's move on to.
For sake of time, yes.
Yeah.
So, okay. So my decision was to, after a discussion with the surgeon, we'll give it a 5 minutes attempt to see if we can actually open the LAD. If not, probably he's going to go to the OR, get put back on bypass and do a revision of the grafts. But again, the concern is he's going to go back and probably maybe get a vein graft to the LAD. That limb is already toasted. So exchanged my system for a 6 French guide. We did not have any 7 French, unfortunately, on the shelf. Don't ask me why. We took a fine cross, and initially we started with a pilot 150, pilot 200. I couldn't get to the LAD. Again, I could not see where the LAD is despite changing my view multiple times. And every time I wanted to cross, I would have to go outside the cath lab, look at the images from the P, and then go back in to try to see where I am in regards to where the native LED is, because I was trying to compare my current images with the P cabbage images. Again, unfortunately, we didn't have supply of wires at that time, and again, do not ask me why, but it has to do with the purchasing issues. But I managed to find a CrossFit 200 that surprisingly went through that LAD. So I changed my my wire then for an Ironman for support, and then started doing my PCI to the LAD, started ballooning. After we're done with the ballooning, we took the IVUS just to try to figure out where is my healthy segment and if my ostium of the LAD is involved and if I do need to cover that left main. And that was the whole purpose, just to taking the IVUS in. So like you can see, the mid segment all the way back is just diffusely diseased with a lot of plaque. And then you can see the proximal and ostial LAD, how involved it is. All the way back now, you'll see the left main in a little bit here. You'll see the left main. There. The left main also has disease in it. So the strategy here is to cover the left main all the way to the mid LAD with a 2-stent strategy, and due to the size discrepancy in the ostium and the proximal LAD and the mid LAD, we decided to proceed with a 2-stent strategy. I put a 275 stent in the mid LAD, and then overlap proximally with a 4030 Resolute stent. After that, I started posting with a 275 in the mid LAD, and then 35, 40 back, all the way to 45 in the left main NC balloon. And as you can see here, we got these excellent results. And
so, by the way, either the patient is in very high dose of vasoactive supported, or that's not a beautiful LAD. Is one of
yes.
those.
So at this stage, we decided to, I was happy with the LAD, I moved on to fix the RCA, which was the culprit. I wish I had a type A lesion in the LAD to start with the PDA, to be honest, in all honesty, but that was decision based on a strategy. That's why I went for the LAD. Yes, and like the doctor said, there's a clip there, I think that was placed where the lima is, and I don't know, maybe is that the reason why the lima is occluded or not.
And do you have the right coronary pictures as well?
Yep. So immediately I moved to the RCA. The one on the right is actually the diagnostic. I really wanted to show how extremely difficult it was to pass this proximal RCA. I started with a whisper wire, and it took me at least 10 minutes just to try to navigate that proximal to mid-segment. After that, and after I got there, I had to put multiple bends on the wire and able to pass this plaque, because every time I push my wire, it goes into that lacerated plaque. So I had to make a big bend on the wire to try to avoid it, but once I passed it, I wasn't able to manipulate my wire. So after I got to the mid-segment, I exchanged it over a microcatheter, and then I got a fresh wire, and I successfully placed it into the distal PDA. I pushed my initial balloon, everything was fine. However, when I tried to push my stent, I could not get it through that proximal segment. So I had to use a telescope, but even the telescope will not go in. I had to use balloon-assisted tracking all the way to get that telescope all the way to the distal RCA to be able to finish my PCI. That's after opening the vessel initially. And then you can see here is my telescope and trying to push my equipment, my stents, ballooning. I put a 275 stent there, postdata with a 275 to high pressure. And then again, same thing, I couldn't pass any stents, and I had to use my telescope to try to get my 4038 stent into the distal mid-segment. Deployed the first stent. I took a second stent as well. That was another 4038 Resolute. And then I had to cover all the way back to the ostium with a third short stent. It was a 4018 Resolute. Then I took a 40 NC and posted the stents. And here are my final pictures. So at this stage, this patient actually is doing extremely well. He was got off the Levofed. His blood pressure was 160, 170 systolic. Again, we had a discussion with our surgeons. Should we put a balloon pump and let him rest overnight? With this kind of blood pressure, we thought, you know what, let's just send him back to the CS ICU. Let's not complicate things, and then let's see how he does overnight. So before we took him off the table, we had also a discussion what to do with this. And I'm not sure what everyone else would do. Would you try to fix it or just get out?
Get out.
Get out. I think that's the smart move to do. So I actually got that patient off the table as soon as possible. I was pushing him myself to get him out the cath lab. And he did well. He went to the cardiac surgery ICU. However, the next day he was a little bit hypotensive. He had the sheath in, so they exchanged it for an intraballoon pump, and that was on August 10th. August 11th, he continued to decompensate. He was hypotensive. His lactate started going up. And at that time, actually, the surgeon was not available. He was in the OR, so I had to put him on ECMO at bedside. And he remained on ECMO almost for 4 days for support. CIRT started August 12th. And then we started the weaning process August 16. He went to the operating room. He was decannulated at that time, and then he was extubated around August 20th. He remained on dialysis for around 2 weeks, and this is his echo on the 16th. He had a normal LV function, preserved wall thickness, and even his RV was normal in size and function as well, as you can see in these pictures. This is another view just showing how the LED territory and apical recovered after the PCI, and he has no wall motion abnormality. As I mentioned, he remained on dialysis for 2 weeks, and then after that, he started responding. He responded to high doses of Lasix. He was taken off dialysis, and his creatinine improved and went back almost to baseline. And he has CKD stage 2. He remained in the hospital for 30 days, and he developed some weakness in his leg due to his critical illness and being in the ICU. But he was discharged with not any issues on all appropriate guideline therapy. He came back to the clinic 1 month after, and he was doing well with no symptoms, walking around and back to his baseline in his life. Questions?
Very good. So thank you. Before I just open it to questions, 2 comments. Obviously,